So our question from New River is not a specific case. There are actually three patients who came to mind, but it's a specific question, and that is about code policy and procedure when patients are in group, in session, and appear to be high. And we've had three cases, one quite recently that we really struggled with, and that led us to bring the question to the group today. The most recent case, actually I'll talk about, it's number 3 on this list. We have a wonderful health educator who has just started holding in-person groups to small groups with appropriate COVID prevention measures in person, small groups to teach life skills and talk about life skills. And the week that this happened, which is a week or two ago, one of our patients who's been in the program for, I believe, a year, and Amy Lively is on the call, she can jump in at any point with these details or to correct me. He showed up to the session and seemed perfectly fine and normal and interactive, and then went to use the restroom and was in the restroom a really long time. I don't know really how long that was. And when he came out, he seemed to this health educator to be high. He was not, he was less, I'd say just drowsy and not communicating. And I don't know what other physical signs that he had, but she really felt that he had gone in the bathroom and used. And there was one other person in the group at the time who noticed a change in his behavior. And she, at the time, stayed with him. He doesn't drive. He has a ride come, and she stayed with him, but she was appropriately upset. I think she confronted him at the time. Amy can help me with the details of this, and he denied it. Later, when our medical director and the director of our program called him about this, he said that he had had a couple of shots before, meaning alcohol, before coming to group, which did not square with what the health educator observed in his behavior. We ended up dismissing him from the program, and we just felt that this was likely what happened, that he had used in the bathroom, and that it was a really fairly severe breach of trust, and put the other patient and the health educator in a potentially very dangerous position. At any rate, that was our most recent experience. We've had another one recently in which a patient showed up. The other thing about this most recent experience was that this was her after hours, her late evening group, 5 p.m. I believe, and she may have been the only person other than the other patient in the building at the time. Another recent occurrence was with a patient who's been in the program for, I believe, at least a year, and who's been struggling a lot during the COVID pandemic. And without getting too much in the details of her case, she showed up, one detail is that at times she does not have Suboxone. On once or twice on her drug screen did not have Suboxone, and has been intermittently using meth and heroin, and showed up one day for a urine drug screen and in person, and was weaving down the hall as the care manager went to get her and bring her back to do her screen. I might let Amy talk a little bit more about the details of that patient's presentation that day. She has since fallen out of the program. She has failed to show up for a number of appointments and has not returned calls. So she's been discharged, although we haven't been able to reach her. She actually, during the past 6 weeks, has also gotten into trouble with the law for not drug-related issues, but is currently has been charged with some crimes. And then, so I'm sort of working backwards on my list here. And the first one on this list is a patient who's been in the program for probably over a year, and at times in the past has shown up to group fairly obviously high, just not able to keep his attention, sleeping, falling over. And I am not sure at the time, this was prior to my being involved with the program, what the response was from our team then. But I don't think he was terminated from the program, and he actually continues in the program. So if he were terminated, he is back in. So that I wanted to keep it kind of brief, but I'd be happy to answer more questions about any details. And also, Amy, I wonder if you have anything to just contribute and clarify in any of those 3 cases.
No, Jennifer, I think you did a great job.
Okay. Any questions? Thanks.
Awesome. Thank you so much. That was excellent. So I'll open it up to the group here. Are there any thoughts, comments, questions about Jennifer's case questions and cases?
And actually, one more comment I'll make just before people jump in is that there are obviously a lot of issues, you know, that this raises, and one is the safety of the patient. One is the safety of the staff. One is the perception of other patients when this occurs, and those are the ones that quickly come to mind, but I'm sure there are more. It just raises a lot of issues. And then those patients who do this clearly needing, you know, it's also a demonstration that something ain't right, as I like to say, and that there needs to be some consequence, whether it's, you know, a higher level of care or discharge from the program or whatever, and should it vary from situation to situation.
Any thoughts or comments? Feel free to use the chat feature as well.
I can jump in. Certainly this happens on occasion, and we've also experienced it in Zoom groups, which has been a different kind of challenge. So as you say, the safety issues are really primary, both safety for the patient and safety for staff and safety for other patients if it is a group setting. So if people have access to security, what we will typically do in our building is the patient will be removed from group. They're not necessarily confronted in group. They're just removed because it can often go bad in an entire group if you get confrontive with a patient in group. So we will pull patients out of group, whether the case manager or someone from the treatment team, and just say, hey, it looks like you're intoxicated. And you know, my general rule is that you can't be in group when you're intoxicated, because that's not great for you and it's not great for other patients, and it's not particularly useful in terms of treatment. So how did you get here today? So we always ask about how they got here, and if they would voluntarily give up their keys, we try and get their keys and call someone for them, or call a cab for them so that they're not driving home. We've certainly had instances where people have refused to give their keys up, and that's typically when we would get security involved, which escalates it. So I prefer not to have security involved if possible, but if I can't, you know, deal with it safely, we'll get security involved. But we do remove folks from group and try and get their keys. In terms of a consequence, it's kind of an indication that outpatient treatment may or may not be the level of care, as you mentioned, that they need. So I think about it less in terms of punishment versus let's get you what you need, because you may not be able to function in this setting, especially as you mentioned, coming to an after hours group where there are not a lot of people around. Like, so immediately they would not be eligible for that group. They would need to be coming during the day when there are more people around and there's more support to help with an intervention. So those are my thoughts.
Yeah, another thing I just want to add is like, you know, we learn from this. Actually, we don't discharge patient because the patient, I think Laura made a good point. Great point is this level of care may not be good enough. So actually we are doing harm reduction. Our goal is to keep, I mean, even the patient, we do our best to retain patient. However, when patient is not suitable for this level of care, actually our job, our main goal is to refer patient to the next level of care. So of course, I think it's individual. Every case is an individual case. So some patients may, if they're psychotic or if they have like a behavioral issue, they may need to be sent to emergency room. Some people may be able to be safely sent to home, but the next level of care is the main thing. I think we have changed that at Chestnut Ridge. We don't use discharge, the word discharge anymore. So we try to refer them to a different level of care. Yeah.
Well, one option to kind of discourage that behavior is to not give the patient Suboxone if they appear intoxicated, and make them return to the clinic the next day when they're sober. And then you can give them the medicine. So you're not reinforcing the behavior with the same, the treatment that we usually provide. And it's also, I'm sorry, it's also useful to have a breathalyzer if someone is walking in an aberrant way. You can do a field sobriety test if you know how to do that. So there's ways to kind of verify this person's unsafe to be like driving or operating machinery.
Yeah, also there's a medical reason why not to give the medicine Suboxone prescription, like Dr. Hirschler said, because a lot if they use benzo, if they're intoxicated with alcohol too much, and of course you have to be very careful because there's a synergistic suppression, respiratory depression problem. We have to be careful. So we do have a medical reason not to give the patient Suboxone the same day as well.
I was going to say, it's important for everybody to know, at least the prescribers, to know that you don't have to prescribe the medicine when you see the patient just because the patient wants it, number one. And I've had many of my colleagues have had the circumstances where somebody's presented intoxicated, and I've just had to tell them, listen, I am not comfortable giving you the medicine today. You appear intoxicated, and all of us can kind of make a clinical judgment regarding whether or not we believe somebody's intoxicated, and you need to trust that clinical judgment. And what I do is usually what Dr. Hirschler recommended is, I want you to come back tomorrow, and so I can reevaluate what state you're in tomorrow, and then we can have a better, clearer conversation about what happened, what's been going on. And from an individual standpoint, then I'm better able to ascertain, all right, is this a one-off? Did somebody slip and get into trouble? Or is this a pattern that really necessitates a higher level of care, or something else going on that really necessitates a higher level of care? So sometimes patients come back and say, yeah, I really screwed up. I was just had a bad day, and this is what we're doing. Then we could deal with it at that time. But don't ever feel like you have to give, or at least my recommendation is, don't feel like you have to give a medication just because the patient shows up asking for it. If you feel like it's unsafe to give that person the medication that day, have them come back the next day.
That's awesome. Thanks everyone for those recommendations. Any other comments or thoughts?
Do you all, this was very helpful, thank you. Do you all ever address with the patient the issue that for the staff, it feels like a breach of trust, especially in this situation where he used during the session on site? It just seems like it would be an important thing to talk about to somebody.
So I think putting it in go ahead.
Laura, I think I think that's a very, very important and key question that would be interesting to hear from others outside of our hub in Morgantown, to hear what people think about that before we offer. So let's hear what other folks think about that.
Okay, so Jennifer, you're saying, how do you address it with the patient and staff?
No, what I'm saying is clearly there's something to be addressed with the patient about their recovery. I think it seems to me there is also something to be addressed about the program and the respect for the program and the staff, especially in the case where somebody would be, it's sort of different if they show up intoxicated. That's a little bit, but this most recent one where he used on the premises, just seemed that should be addressed as a breach of trust of the team.
Okay, so if I am sure and have confirmation, not just clinical suspicion, that he used, like he showed me, or she, if they showed me what they use and so forth, I would either consider escalating a higher level of care, because clearly if someone's addiction is so bad that they're actually using in the meeting, they need a lot of help, right? And at that point, I would think maybe you need to go inpatient if you're not able to hold off. So I talk to the patient and ask. In terms of like breaching safety and trust, I think that kind of goes along with addiction when you're in active use. I mean, when it happens to me, because I'm sure I've had several patients show up high or just before they came in, you just don't take it personal. I just know that's the part of the disease, and it just means that their disease is extremely severe. And so I try to support the patient as much as possible. Now, if it became a repetitive pattern of behavior, then clearly that's going to affect the other members of the group if they see that happening, and it disrupts group dynamics. So then that patient would be asked, I would dismiss that patient from the group and recommend a higher level of care.
Very helpful, thank you. And there was a chat too that was helpful.
I think that, just an increase of level of care and it being addressed with the patient, that's not appropriate, and increase their treatment probably would be appropriate.
It's taken me a long time.
Hi.
It's taken me a long time to get to a place where I don't take it personally whenever someone is lying to me. But I think I finally got to a place just this year where when someone is lying to me, rather than feeling like, oh, I can't work with you, I feel like, oh, I have to work harder to gain your trust. And I don't know, I don't feel like, I don't know why before I thought that I should automatically, they should trust me, but it slowly went away over time. I don't know what caused that.
Beth, was there something you wanted to say as well?
Did you say me?
Yes, I noticed you had.
Okay, you're right. Sorry. Okay. I know I've brought this up before, but it is a big problem. And we have also, just in the past week, actually experienced pretty much the same thing. Someone came in that was intoxicated. They didn't use on the premises that I know of. But anyway, my question is, we can try to refer them to a higher level of care, but what we keep running into is there's nowhere for them to go. I had one girl in my office, I guess it was last week, and she was ready to go. I could not find anywhere that would take her. I ended up calling the, what's the number, the 1-800 for help for West Virginia number. And I talked to a very kind lady there, and it was just so discouraging. So I held this one girl, kind of like she's continued to use meth over and over and over. I don't know what to do at this point. I mean, I'm afraid the message that's getting out to our people is that it just doesn't matter. what you do. And it's like I said, I had at least one guy and possibly two last week show up for group that were intoxicated. So I don't know. Is there anything else we can do?
I think one thing that's helpful to look at this is that the behaviors that patients display in their interactions with the clinician often reflect what their behavior is like in the rest of their life. So if somebody comes to the clinic intoxicated, they probably go to work and intoxicated, or an important event in the family, they're probably intoxicated. And so it's that kind of level of loss of control. And so it's giving you a display of what's happening in this person's life in this little microcosm of the clinical setting. And so I think it helps to look at it that way, as, you know, this is this patient's life and how can we offer the treatment they need to rein this in.
I think two things I want to add here. So one is the next level of care. So a lot of times we, you know, I understand it's very hard for you to find the jump number, like ASM number, like from 3 to 4 or 2 to 3. But we can create a level of care, you know, just based on our, you know, what our resources, clinical resources. For example, if you increase the frequency of therapy sessions or visits, then that is a different level of care. So it's not really, you know, a big change, but it could be, you know, it could be more helpful to some individual cases. So the second is, I think, yes, when I see a patient in my own clinic, it's different from seeing a patient in code clinic, because a group is a group. I have to think about the whole group care. I'm not just, you know, if this patient is intoxicated in front of the group, and that definitely, that kind of behavior will influence other people, and definitely will affect, you know, addiction care and recovery of other patients. So in that case, yes, we definitely have to deal with it, you know, seriously. So I think it's different. I mean, we can always see patients in our, you know, own clinic, provide individual treatment, and in combination with, you know, other, we're talking about, you know, treatment modalities. But individual patient visit is different from group practice. Yeah.
Thank you. So we have about half the session time left, and I want to leave enough time for the didactic as well. But before we do move on, are there any other final thoughts, comments, recommendations? I always hate cutting the conversation short, but.
So I have a list of resources that one of our recovery coaches put together here, which is not every single place in the whole state, but she did a really nice job, and it also includes contact folks if people would like me to share that with the group.
Absolutely, that would be great. And you could always email that over to me and I'll make sure to send it in the recap as well. We got a chat in saying, yes, please, enthusiastically. So okay. Awesome. Any other final comments, thoughts, or questions?
I would say that I agree with what Dr. Zhang was saying. If you can hear me right now, I think I fixed my mic problem.
We can hear you, yep.
Cool, thanks. What I have done in a situation like that, because we don't have different levels of care where we're at with health, right? Although we're in the process of trying to set up an AP code. But I've scheduled them with more appointments with me. And we've also worked with Friendship House, which is a subsidiary of ours, to set up regular meetings with their recovery coaches through the week, so that if they do need more social support or peer support like that, that we can get them in there. So we're constantly getting them into something to try and manage this a little bit better.
Awesome, thank you. And I am working with Laura and Emily to do a mock role play teletherapy session for OUD. So definitely keep an eye out for that and bring your questions to that as well. But okay, that was awesome. Thank you, Jennifer, for those excellent cases and questions. Dr. Husted, anytime you're ready, I'll turn things over to you. You can just share your screen and pull up your didactic.
Cool. Well, I appreciate everybody coming, the group. This was originally going to be 1, possibly 2 lectures. I think since we had such a good discussion, it's probably going to almost definitely be 2 now. Let me see if I can share this okay. It was working earlier, so hopefully we get there we go.
Yep, we can see it on our end.
Okay, that looks good.
Yes, perfect.
So, stigma is such a big part of addiction treatment. Unfortunately, it's something that affects the way we treat people. It affects the resources we have. It affects the patients themselves. It's something I've been kind of increasingly more interested in over the last few years. I believe Laura did a lecture earlier in the year on stigma, kind of a specific thing. My push is more like actually fighting through stigma and combating it, just because I've seen the barriers to care that it causes. So this will probably end up being a two-part lecture. There's a couple specific case examples of things that I've kind of run into over the years, unfortunately, due to stigma interfering with patients. And it doesn't take very long if you keep your eyes open, you'll catch it yourselves in whatever clinic you work at. I guarantee you that. So this was actually a lecture that I had given before last year when I was applying to be faculty. So some of the faculty here might have heard it and some of them might not have, but I've kind of adapted it a little bit. But fight the good fight, combating stigma and addiction treatment. So disclosures, I don't have any disclosures, no pharmaceutical ties. We'll mention some medicines, but now assistant professor here, which is kind of crazy. I had to change all my old presentations, update that. So I'm running the inpatient DDU these days, and it's going pretty well. Special thanks to lots of doctors, including some of them are on right now, Dr. Berry, Dr. Zhang, Dr. Chandran, I didn't see him, Dr. Sullivan. All right, so the objectives of this are really, we'll talk about stigma, we'll define it and kind of the domains of stigma. So there's different domains to it. We'll address the issue of stigma and addiction treatment. Again, it's so prevalent. We'll make the case for utilizing effective advocacy, so to combat the stigma. We'll talk, if we have time, or probably it'll end up being next month, we'll talk about two cases where stigma affected treatment. So two cases I was involved in the last couple of years. Examples of how we can use advocacy to combat stigma. And then some lessons learned from advocacy. So certain stumbling blocks that I didn't anticipate over time when I started taking this on. Things that you really wouldn't imagine being an issue. And then over time, when you start doing advocacy work, you start to realize the things that repeatedly come up over and over again. And really the goal, try to be interactive. I've not mastered fighting stigma, so I wish I could say that I have the answer to any type of stigma that people deal with, but that's far from the truth. It's really something you have to work at, and hopefully you'll learn something. So, all right, so what is stigma? The definition of it. So stigma is the noun, stigmata is the plural, but it's a mark of disgrace or infamy, a stain or reproach, as on one's reputation, or mental or physical mark that is characteristic of a defect or a disease. I like this definition. So stigma is a perceived negative attribute that causes someone to devalue or think less of the whole person. So really when we're talking about stigma, we're talking about us viewing people differently, us treating people differently. It's amazing, I'm sure we've all experienced it, but it's amazing how different someone's treated if suddenly someone gets a wind that they have a substance use disorder or they're on MAT or whatever. It's amazing how different suddenly services will approach that person. So it's a perceived negative attribute that causes someone to devalue or think less of the whole person. So somebody's not as important. So prevalence of mental health and addiction in the U.S. So how prevalent is these stigmatized forces that we talk about? So about 1 in 5 adults in the U.S. experiences mental illness in a given year. So that's a lot of people. Approximately 1 in 25 adults in the U.S. experience a serious mental illness in a given year that substantially interferes with or limits one or more major life activities. So a lot of people deal with this. About 20.2 million adults in the U.S. experience a substance use disorder. And about 50% of those, or about 10 million people, had a co-occurring mental illness. So substance use disorder is obviously extremely common. Mental health issue is extremely common. They both get kind of lumped into the area of things that are kind of icky, and we don't want to deal with them, right? We treat people different if they have a mental illness, or we treat people different if they have a substance use disorder. I had to laugh. One time I was asked to do a grand rounds. I won't mention the place, but they wanted to know how to detox people from alcohol, try to just have kind of a standard approach for everyone there. So they asked that, and then they also asked, we'd also like to know how to deal with psych patients, quote unquote psych patients. And it made me laugh, because I actually asked them the day of, I was like, so what do you define as a psych patient? Is it somebody you don't like, or is it somebody who's on psych medicine? Is it someone that has a disorder? It's so vague, but we know what they're talking about when they say that too. So, stigma. So stigma and substance abuse, substance use. So it's real, it's prevalent in treatment of substance use disorders. I don't think anybody here would not agree with that. There's many otherwise good clinicians who continue to view addiction as simply a bad habit or a choice, and not as a disease. So I think fundamentally, if you only view substance use as a bad habit, it's impossible to really fully appreciate it, how serious it is, really. So viewing something as a bad choice rather than a disease, there's no way that this doesn't change the way you approach the treatment and the patient. I think it's almost impossible to kind of put that aside if your underlying belief is it's simply a bad choice. It's impossible for that not to change how you treat the person. As clinicians who care for substance users, so us, our goal really should be to decrease stigma through the use of effective advocacy. So, if we're going to treat these folks who struggle with substance use disorders, if we're going to use Suboxone, if we're going to use other things, we need to treat them, we're going to run into stigma. So we should try to know at least how to be effective advocates and help these folks, because it is definitely going to interfere with our treatment. So the 4 domains of stigma, it's my wife and my son, although we have a 4th edition who you guys get to meet next week. So there's really 4 domains of stigma. Some people would say maybe more or less, but personal stigma, which is kind of interesting to get into. There's medical stigma. There's stigma in the criminal justice system. I did this presentation originally in like August of last year, but probably this has come more to the forefront, criminal justice stigma for different things. And then the overall societal stigma, which I think is what Laura talked about before. All right, so personal stigma is very interesting, but a subjective process that is characterized by negative feelings about self, maladaptive behavior, identity transformation, or stereotype endorsement resulting from an individual's experiences, perceptions, or anticipation of negative social reactions on the basis of a stigmatized social status or health condition. So this is really turning inward towards a person. So what people don't realize, I don't think sometimes, but for those who haven't experienced the substance use disorder, is that, there's a lot of guilt with it, with your substance use. And, if you have the mindset, which most people do, is it's kind of us and them. So us being the non-substance users and them being people with addiction. When you personally start struggling with a substance use disorder, obviously at first there's a lot of denial, right? So I don't have alcoholism, or I don't have this, or I don't have that. I have control. When you cross over from the us to them, now you're suddenly putting yourself in this area of people that you previously couldn't stand, right? So we had a guy a couple days ago on the DDU who he mentioned how growing up he drank alcohol, but he'd see people that did opiates, and he'd call them junkies and this and that, and he couldn't stand being around them. And then suddenly when he started struggling with opioids 5 years ago, he couldn't say that anymore, right? And so now people actually kind of turn the stigma to themselves. So they're not worthy of treatment. So shame, very much a common denominator in people because of personal stigma. And this often interferes with people seeking treatment. So, you know, I'm now this bad person. I'm this marked person. I'm no longer who I was before. I don't really deserve help. That is something you'll come across. And a lot of these people aren't showing up to our clinics, right? They're the ones that probably need to be, but they're not. So one of the things that kind of furthers personal stigma is the use of labels. So I know in peer recovery situations, these are often kind of badges of honor, but really the push is to not use these kind of this terminology. So, you know, junkie, alcoholic, you know, are you dirty, are you clean? Try not to say that stuff anymore. So say, you know, are you somebody that uses IV drugs? Do you struggle with alcoholism or alcohol use? Are you sober, or are you still using? So you have to be really careful about the terminology that you use, even though sometimes they'll say these exact things back to you. But as physicians, clinicians, we try to avoid saying these things. So personal stigma, often under-recognized. So medical and criminal justice system, this can be kind of lumped together, what you may call kind of a structural stigma in a way. So these are the rules, policies, and procedures of institutions that restricts the rights and opportunities for members of a stigmatized group. So things that are kind of on the books that lead to us to treating people differently, right? And I'm sure we could all think of a few pretty quickly that we deal with day-to-day basis. It's evident, again, we already mentioned, but when you see how somebody with a substance use disorder, or even somebody who has a suspicion of one, is treated compared to someone who doesn't. One of my favorite lines I like to do is, if somebody's in the hospital and they're really sick, and they just had to have surgery, and you know, they haven't been stabilized on MAT or anything like that, and we'll have surgeons or whatever ask us, you know, how do we treat their pain? How do we treat their pain? We just say, just treat them like anybody else for right now. How would you treat someone who just had a valve replacement, or, you know, just had spinal surgery? How would you treat them? We can worry about the substance. We're going to still worry about the substance use, but just treat them like anyone else. There's legislative actions that routinely exclude or limit the scope of substance use treatment. You know, everyone here who prescribes buprenorphine, you know, right there, 30 patients to start, 100 max, sometimes 275 if you jump through some hoops. What other medicine is there that you have to worry about that? It doesn't exist. Or how many, we talked about the concern with higher levels of care. You know, if somebody does need to be in a methadone clinic, how many methadone clinics are we permitted in the state? Not many. That's all legal structural stigma. You know, it's unfortunate, but its reality is people who are hospitalized can be often get, you know, a lot of people on staff will kind of go after these people if you're not paying attention. And it's unfortunate, but it's a reality. I remember one of the nurse practitioners, I don't think she's on here, but she talked about, she had a presentation for some of the OB staff, OB nurses, and she had all these quotes from nurses about, you know, you're a horrible parent and you're this and you're that. And when she gave the lecture, everybody was appalled by what they saw. But then she disclosed, hey, I got this. These are all like firsthand accounts of things that I heard when I was working in the OB floor. So it's amazing, but it does exist. And it's something that's worth fighting against. Societal stigma. So the phenomenon of large social groups endorsing stereotypes about and acting against the stigmatized group. So for substance users, societal stigma is deeply entrenched in the culture, right? So again, the idea of kind of us and them. So them being the bad drug addicts that we don't want around us. You know, we don't want these people in our communities. We don't want them treated in our communities. We just don't want to deal with it. You know, commonly we'll hear, you know, we want them to get help. Yeah, I don't want my cousin to die, but I don't want them to get help here. You know, my kids live here. I can't imagine having a Suboxone clinic or a methadone clinic. My God, what's going to happen? The city's going to go. You hear this kind of stuff all the time. And it's very unfortunate, and it really pushes people away from wanting to get treatment. So oftentimes what you'll find if you dig down is that there's a lot of misinformation about substance use. I'm sure probably some of the people that are here today, you know, over time, you've mentioned how, you know, your views have changed a lot, how kind of we mature over time, and we understand a lot more about addiction now than we did even 20 years ago. So there's still a lot of misinformation out there. There's a lack of education, and that's a prime real estate for us to kind of step in and try to help out and teach people what's really going on. I mean, there have been some legislative changes been made to combat stigma that exists societally, but again, this stuff, we have a long ways to go. You know, we can fund as much additional fellowship training as possible, or, you know, put more money towards this, but until we start changing hearts and minds, it's not going to really change anything. So using advocacy to decrease stigma, again, something over time that I've become more and more passionate about, just because I've seen how I can have someone doing really well and then stigma gets in the way of their recovery. But what I would say is advocacy, it really is a core component of being an effective healer. So if our hope is to try to heal people, you know, to help them with their treatments, we need to be prepared to be advocates for those people, especially with substance use. There's opportunities that are readily available to be an advocate, not only for our patients, but also for the field of addiction treatment and for one another. So, you know, the way I think about advocacy is, you know, you start on the patient-to-patient level. So, you know, if I'm seeing a patient and I hear them say something like, well, I'm just a junkie and I don't deserve this, or I don't deserve that, I'll say, well, you know, you have a disease of addiction. Not everybody has it. It's unfortunate you do. I wouldn't wish it upon anybody. So you're just like anyone else in terms of, you know, this is difficult for you. We're going to try to treat you and try to help you as much as we can. So starting on kind of the base level and then moving your way up. So, you know, if you see some kind of wrong that needs righted, you know, insurance companies are refusing to pay for medicine, or, you know, we have a situation right now that a lady who really wants to go to a 28-day program, which is great. She can only go for part of the time because she has other obligations, but her insurance pays for one lifetime trip to for addiction treatment. So she has one chance to get better. So things like that. And then, you know, being advocates, again, for just the idea of for each other. So, you know, how many times have we heard someone say, at least I have, say, okay, that person's on Suboxone. I heard that's bad. I heard that's worse than heroin. I'm like, well, you know, I don't recall Suboxone killing, you know, 20,000 people last year. I think heroin did, if I'm not mistaken. So trying to advocate for one another. You know, if you have a clinic and say, you know, those folks, they're doing a good job there. I think you stick with you know, try to work with them. That kind of stuff can go a long way. Again, you know, when you do advocate for substance use disorders, you can do it at many different levels. So whether it's with the individual patient or more kind of broader, you know, if you have an in with those who make decisions at your healthcare system, that could be a huge thing where, you know, you're starting to tear down barriers. You know, we're going to have buprenorphine on the formulary. How many hospitals are that don't even carry it? You know, somebody's expected to bring their own medicine in for 6 weeks of antibiotic treatment. So with personal stigma, again, talking to individuals, you know, person to person, normalizing addiction as a disease. You know, it's a disease, we're going to treat it just like another disease. I mean, it's more complicated largely than any other disease, but we're going to try to treat it from a medical perspective, just like any other disease. Medical stigma, working on the old guard, so to speak. So there are genuinely some people that just don't believe in addiction treatment or mental illness for that matter, but also teaching the next generation of providers how to be better than the way we were. Criminal justice system, this is something we'll talk about. I'm definitely going to be talking next time on the same thing, so we're not going to get through this, but criminal justice system. So, meeting with judges, meeting with parole officers, talking with police, CPS involvement, that's kind of inevitable, unfortunately. And then really societal, trying to disseminate information to the public, working on legislative changes, so bigger picture stuff. So trying to master kind of the personal stuff, being able to talk to someone one-on-one, being able to work with, people in our field, so talk to our colleagues, and then moving up to more and more kind of difficult, if you will, so criminal justice, societally, bigger picture. So advocacy and graduate training. So these are kind of three emerging themes that I find interesting. So conceptions of healthcare advocacy have evolved towards advocating with rather than for patients, communities, and populations. So the idea that you're working with people that struggle with substances. So, there's nothing better than being able to put somebody up on stage with you that's overcome an addiction or has it under control, and they've used processes like this. So getting to know people, maybe some of your most stable patients, and sometimes enrolling them with to help you with these kind of things. Longitudinal curricula were less common, but appeared the most promising, often linked to scholarly or policy objectives. So the idea of teaching students throughout their graduate training how to treat addiction. So not just 1 hour of class or 2 hours, even a couple of weeks over doing substance use disorders, but kind of teaching them throughout their careers how to manage this stuff. Hands-on, immersive opportunities, building competence, confidence. So again, there's no substitute for actually doing this stuff and getting to know that, people do get better and you can make a huge impact on their lives if you're willing to put up with some of the stuff we were talking about earlier. So community identified needs and partnerships increasingly considered in designing curriculum. So the idea is that, you're going to the community and you're seeing, what are you guys struggling with? So an example that comes to my mind is, when we start hearing that a certain pharmacy isn't allowing somebody to fill their medicine, or a specific pharmacist is refusing to. Those kind of things. And then also with graduates, let them actually lead it to the medical students, the fellows, the residents. Help them to actually do those kind of programs, because engaging those guys, it really helps. So let them lead it. Let it not just be, coming from down on high saying you need to do this, you need to do that. Let them design some of this. That'll help. So I think it's 4:57. So this is probably a good time to stop. But, the next time we speak on stigma, I'm just going to give you two very concrete examples of cases that I've dealt with and how I tried to approach it and made things maybe a little bit better on both ends. It seems like every time I come up with one of these, another one's kind of brewing in the background. I know we're dealing with a big one right now that we might share with you guys down the line. But I hope this was a good kind of prepper for it. So.
Absolutely, that was excellent. Thank you so much. So we do have a few minutes left. Any questions? And we will schedule a part 2 to finish the didactic in the future here. But any thoughts or questions for Dr. Husted?
I have a super quick question. When I presented today, I'm fascinated by language, and it's been really helpful for me over time to learn about language related to stigma. So today when I presented, I said hi, and all responding hub members said intoxicated. So should I switch to saying intoxicated instead of saying hi?
I don't think that one's as bad as like calling somebody, a junkie or something. I mean, I don't have an opinion on that one. I probably still say hi, but I catch myself saying certain things sometimes. So we can all do better. We'll put it that way. Intoxicated is probably the more medical jargon sounding word. So I think intoxicated would be fine.
But when you think about talking to a patient who's actively under the influence, sometimes if you use the language like hi, it will be more antagonistic than if you say you're not yourself, or you appear like you may have taken something, just to kind of use language of de-escalation.
Yeah, thanks.
Awesome. All right. Thanks, everyone. So before we do part ways, I just have a couple quick announcements. So our next session will be on July 27th, and Laura Lander is providing the didactic on treatment of co-occurring OUT and methamphetamine. So keep an eye out for the reminder for that. And one other brief announcement is that Zoom is requiring us to do passwords now, unfortunately, to join meetings. So we'll find out more about that, and I'll inform all of you guys for the future in case that is actually a thing. So thank you, Jennifer, for the cases. Thank you, Jeremy, for that excellent didactic. I'll work on coordinating a part 2 for you, and we'll see you all next time. Thank you.